All right, good evening, everyone, or afternoon. Um, my name is Jamie Ard. I am the Chief Science Officer for Advocate Health and Executive Vice Dean at the School of Medicine. It's an honor to be here. Great to see folks I haven't seen in a year and be back in the area as a part of our Celebrate Research this evening. So thank you for joining us here. Those who are here in person and virtually, those who are joining us online, it's wonderful to see everybody as a part of our gathering for Celebrate Research 2026. And as you know, this is part of a month-long celebration where we're really celebrating discovery and translation of research into products and services and care delivery that help change the lives of our patients on a day in and day out basis. Research is that thing that helps us turn that possibility into progress and discovery. So we're here today to talk about neuroscience, and I'd like to maybe say a couple of things about why neuroscience research matters. We know that neurologic conditions affect millions of people, and they can profoundly shape the quality of anyone's life. Diseases of the brain and nervous system remain among the most complex challenges in medicine. Advancing care for these conditions requires deep scientific curiosity, clinical expertise, and collaboration across multiple disciplines. Research allows us to better understand the brain, develop new treatments, improve diagnostics, and bring hope to patients and families facing these devastating diseases. As the academic core of Advocate Health, Wake Forest University School of Medicine partners with teams across our health system to advance research that improves care. Our investigators are exploring new approaches to neurologic diseases, from clinical innovation and emerging technologies to new models of patient-centered care. This work reflects the strength of our academic learning health system, where discovery and clinical practice continually inform one another. Through this model, insights generated through research can translate quickly into better care for our patients. Tonight's program highlights the outstanding neuroscience research taking place across the Advocate Health Wisconsin division. The investigators you will hear from are leading important work that is directly influencing how neurologic care is delivered here in this area. Their efforts demonstrate how discovery can move from research programs into clinical practice to improve care for our patients. This kind of impact is exactly what Celebrate Research is all about. We want to highlight and celebrate the collaboration that happens across our health system. Progress in neuroscience depends on that level of collaboration. It requires all of us, clinicians, scientists, the teams that do the research, and care delivery teams to work together to better understand the brain and diseases that affect it. Events like this give us a chance to share these ideas, build partnerships, and accelerate discovery. Every breakthrough in neuroscience begins with a question about how we can better understand and care for the human brain. So, as we open up the program, I want to invite Dr. Amit Acharya to bring us into the beginning of the program. I want to thank the teams across the Wisconsin division who are advancing neuroscience research and improving care for the patients every day. I'm also grateful to Dr. Sean O'Leary, who is our Vice President of Neuroscience Service Line, for moderating tonight's discussion. It's my pleasure to now introduce Dr. Acharya, who I'm sure everybody in the room knows. He's the president of Advocate Aurora Research Institute and Vice Chief Science Officer, Vice Dean for Regional Research Strategy and Integration at the Wake Forest University School of Medicine. Dr. Acharya is a professor of public health sciences and a nationally recognized leader in biomedical informatics and translational research. His work helps strengthen research, collaboration, and innovation across Advocate Health, and it's been my pleasure to be a partner of his in this journey. So please join me in welcoming Dr. Acharya.
Thank you, Dr. Ard. That was way too kind. Hello, everybody. Welcome to St. Luke's, Wisconsin. It's great to see so many familiar faces here. As Dr. Ard mentioned, today we are gathering here, a lot of you in person and a lot more online, to celebrate the work that's happening here, led by each and every one of you. We have our research teammates, our clinician researchers, our clinicians, other teammates. We have our community members, our donors. We have our industry partners. It's so nice to see everybody. And it's a celebration of all of us. They say research is a team science, and it takes a village, and everybody plays such a huge part. But at the end of the day, the purpose is, we bring this to our patients and the communities that we have the privilege to serve. And not only from discoveries and innovation, but for that to reach our patients and the communities, that's kind of the goal. And Dr. Ard said it so well. It's the academic learning health system model, and how each one of you plays such an important role, to kind of moving the research and the portfolio of all of the work that's going forward. And again, today we are celebrating neuroscience and all of the research that's happening. I've had the pleasure and opportunity to work with Dr. O'Leary and all of the members on the panel. You'll hear from them in terms of what work they've been leading, not just here in Wisconsin, but also in Illinois and in the Midwest, and from academics to kind of industry-sponsored work to some of the innovative work as it relates to kind of data science. And I think one of the hallmark of the program, what I've witnessed over the last 5 years of my tenure here, is our clinicians and researchers really leverage the infrastructure and the key assets of the health system to kind of bring it back to our patients. So you'll hear from each one of them in terms of some of the amazing work that's going on. And for me, as I'm reflecting on this week, I cannot just think of the huge strides that we've made just in the last 3 years, coming close with the true academics of what Wake Forest School of Medicine is kind of driving, serving as the academic core for us, as well as really bringing the local support that we need. And I cannot thank Dr. Ard for his leadership and Dr. Boulware for her leadership, and everything that we are doing to kind of connecting each part of our health system, where nobody should feel, whether you're a clinician or you're a research teammate, sitting in Green Bay, Wisconsin to Macon, Georgia, the experience should be the same, because end of the day, when you excel, our patients excel, and we can give the best of care for them. And as I went through this week, it was just amazing that this is Wednesday here, and the third state that I'm getting to be. Monday was in Winston-Salem, yesterday was Illinois, today is Wisconsin. Just makes me realize how large we are and the impact that you all are having. So it's such a great event to celebrate you. And with no further delay, I would like to kind of welcome Dr. Sean O'Leary, but I would not want to miss an opportunity to kind of call out and recognize Dr. Lynn Waganak and Dr. Christina Verdui, and many people in their team who planned this. And as Dr. Ard mentioned, this is not just one evening event. A whole month we've been celebrating across all of the Advocate Health footprint. So with that, Dr. O'Leary, please welcome, and thank you for your leadership and your partnership.
I have the really easy part now to do for you and introduce our first speaker, Dr. Dean Carhalios. He's our Director of Neurosurgical Science Services for the Midwest and co-director of our Spine Surgery Fellowship. Dean will be talking to us virtually today on some recent research he's doing related to spine pathology and its imaging. Dean, I think, is online now, and let's see if we can get him to go. There he is.
All right. Thank you, Sean. Good evening, everyone. I regret not being able to be with you in person because of some trauma call responsibilities here in Chicago, but nonetheless, thank you very much for the opportunity to present a brief glimpse of our work in the area of novel imaging that allows us to objectively identify the location of pain generators in the spine. Next slide. Well, here's the scope of the problem. Axial spine pain, especially in the lumbar region, is endemic in the US. The majority of Americans will experience significant back pain during their adult lives that requires medical attention. I'm confident that many of you in the audience have had or will have bouts of pain that will prompt you to do the same over the course of your lives. The cost of this is tremendous. Low back pain treatment is one of the largest single diagnostic entities that our government pays for, and it represents about 2% of our total healthcare expenditure. So you can imagine it's a very big number. Next slide. The first problem, though, is where's the pain coming from? And if we don't know where it's coming from, we don't know how to effectively treat it. So how do we narrow it down so that we can effectively target our therapeutic interventions? It's helpful if there's something in the history or the exam that can point us in the right direction, such as radiating or radicular symptoms. However, the locus contributing to a patient's neurologic presentation is not always the locus of their axial pain, or there may be additional levels contributing to the constellation of symptoms. Further, the correlation between imaging findings such as the Fuhrman grade or modic change, which you can see on imaging, and specific pain generators has been proven somewhat unreliable. In a patient with back pain only, definitively identifying the locus of mechanical pain is challenging, to say the least. And for this reason, spine surgeons have avoided operating on such patients, as the outcomes accordingly have been less than optimal. Next slide. So how do we get at it? Invasive diagnostics can help us a bit more. They can be effective in getting us a little bit closer to identifying competent loci related to axial pain. Prominent among these are targeted facet joint blocks, facets being one of the most common locations for pain, and provocative discography targeting the discs, which is the second most common. However, there are confounding challenges associated with these modalities. There are often too many potential targets that can only be definitively evaluated by serial focused study, which can be logistically impractical to perform thoroughly. This process takes a lot of time and often is further marginalized by poor patient insight and a lot in the way of inherent interviewer bias. Next. Over the last few years, we've seen the development and rapid adoption of some new imaging modalities that provide accurate and above that objective results that identify pain generators. As an example, we've been using SPECT-CT, which demonstrates areas of increased radioisotope uptake and areas of inflammation. It turns out that this modality is very sensitive and specific at identifying facet joint mediated pain, but less so if the pain is related to degenerative disc disease. So as a result, we've been looking to an even more novel and objective modality to identify discogenic sources of pain in the way of MRI spectroscopy. Next slide. MRI spectroscopy, like any spectroscopy, allows us to measure the presence of chemical biomarkers that are known to be related to discogenic pain and to the overall structural health of the intervertebral discs. It's been concluded that decreasing collagen and proteoglycan signals are related to advancing disc degeneration. And further, the relative accumulation of acidic molecules like alanine, lactate, propionate, these are associated with pain, most likely related to the effect they have in a low pH environment on nociceptive pain fibers. So by analyzing a spectral analysis that identifies the peaks of these biomarkers, one can make certain conclusions regarding the relative health of intervertebral discs. Next slide. So we are able to generate a report called a nocigram. There's two components to it. One is the NOCIS score that looks at the acidic biomarkers, and in the next slide I will show you the SI score. But the NOCIS score, in this case example here from the landmark study that validated this modality, the results of provocative discography are seen on the far left in the red and green. Then there's a mid-sagittal T2 weighted image that shows that L3-4 and L5-S1 were deemed to be concordant pain generators based on provocative invasive discography. Now, to my eye, the L3-4 just looks like it's pathologic just based on its darkening. L5-S1 looks pretty good to me, but based on the provocative discography, L5-S1 was a painful disc. Now, when we apply the spectroscopy to this disc, we in fact do see exactly what the discography showed, which is that this is a painful disc. There are acidic biomarkers present in this disc, and that it should be considered a competent locus for discogenic pain. Next slide. The second component to the nosogram is the SI score, the structural integrity score. An SI score, again, is derived from calculations related to collagen and proteoglycan levels, normalized to the highest value between discs for each calculated parameter, then averaged for a total SI score. So you're comparing discs for in a single patient in a single exam. A low SI score corresponding to low structural integrity is in general associated with more advanced degeneration or relative between the discs in that same patient. It's important to point out that higher SI scores reflect higher relative values as compared between discs in a patient and do not necessarily reflect high structural integrity. So you can imagine a patient that's got a lot of discs that are in bad shape. The best one is going to have a score of 1. So it's comparing discs within the same patient. In this case example here shows that the Fuhrman grade, or the appearance of the disc at L5S1 in this case, does not always correlate with biomarkers associated with loss of structural integrity. You can see here that the L3-4 disc that looks okay based on its Fuhrman grade actually it has a lot in the way of loss of important structural elements in the way of proteoglycans and collagen. Next slide. So what are we doing with this information? Here's a quick rundown of some recently concluded and active studies on MR spectroscopy. We are currently enrolling in the Clarity trial there at the very bottom, and we'll be prospectively evaluating surgical outcomes in cases where the surgeon is or is not blinded to the results of spectroscopy during preoperative surgical planning. And we hope to see if that, at the end of the day, once the surgeon is made aware of the preoperative findings of spectroscopy, did that influence the outcome in any way? Next slide. So in conclusion, MR spectroscopy can provide useful and complementary information regarding the location of probable pain generators involving the discs, allowing the clinician to accurately, rapidly, and actually in a very economical way and a non-invasive way target discs for therapeutic interventions. Ongoing research, as in this Clarity study, will hopefully provide us with insights that will help surgeons determine the location of discogenic pain generators so that they may be included in the formulation of more effective treatment plans. Next slide, please. Thank you.
Thanks very much, Dean. We'll have a chance for many questions at the end. And to Jamie, we wanted to come out of the gate early on with highlighting the central nervous system, including the spine. So we're back to the brain now with Darren. So our next speaker, Dr. Darren Gittleman, is our Senior Medical Director of the Advocate Memory Center in Park Ridge, Illinois at Lutheran General Hospital. Also the Co-Medical Director of Research, Neuroscience Service Line, Midwest Advocate Health, Director of Cognitive Disorders, Advocate Medical Group, and also Professor of Neurology at Wake Forest University School of Medicine. He also had a busy week. Last night, won the Best Places to Care Award for research and mentorship, so good job there. So that was more the red carpet kind of stuff, and today we'll talk more about the day-to-day work for yours. Thanks, Darren.
Okay, are we on? I guess we are. So thanks for having me. I want to tell you a little bit about the research we've been doing, mostly in Illinois, although some of the studies extend into Wisconsin. And I'll do the slides. So I help lead the Advocate Memory Center. We was founded when they recruited me in December 2014. It is supported by philanthropy with the mission of the center being for research into the cause and prevention of Alzheimer's disease and care of those afflicted with the disorder. And that's really been our guiding light throughout our existence. We have a clinic where we see patients. We do clinical trials research at the center, educate our community, and participate in education of our colleagues. Oh, and I should say, we started out with 3 people, myself, a social worker, and a clinical trial coordinator, and our group is there. We just recently took a picture, so it's grown quite a bit. So patients are really why we do everything in research. So I'd like to start with some patient stories. These are not real patients, but sort of combinations of patients. So Linda is a 75-year-old woman. She has mild Alzheimer's dementia. She and her husband know there's no cure, but they're interested in the latest research. And so our studies have focused on symptomatic Alzheimer's disease treatments, and I'll talk about those. Isabella is 35 years old, so young, except she, in her family, has autosomal dominant familial Alzheimer's disease, and she may inherit that gene. And she wants to know, what can be done maybe to help prevent her from getting the disorder or to help future generations. And we are involved with autosomal dominant AD research. And then finally, Calvin, he's 55. He has hypertension and diabetes, both increased risks for dementia and Alzheimer's disease. And he also knows that African Americans have double the risk of white Americans in developing Alzheimer's disease. So what can be done for him? What are the lifestyle factors that may make a difference and may reduce his risk of dementia in the future? And we've been involved with that research as well. So I'll give an overview of some of our clinical trials. We've worked on studies in diagnosis, biomarker studies, symptomatic AD industry-sponsored clinical trials, talk about some studies in genetic Alzheimer's disease, lifestyle and other medical interventions that may help prevent or reduce the risk of Alzheimer's disease, talk a little bit about our clinical trial recruitment, and we are part of the Global Alzheimer Platform Network of high-performing clinical trial sites, which is a national organization. So in the Alzheimer's disease diagnostic biomarkers, many of you who are old, like me, may have grown up under the idea that Alzheimer's disease was only diagnosable at death. People had to go through autopsy, only way you could be sure and make a diagnosis. And that's been true for much of my career. But in the last few years, other biomarkers have become available. So we were involved with the IDEA study, which was a study that looked at amyloid PET imaging. This started in about 2014, 2015. And was to show at the time the value of having that in making a diagnosis. This was before we had the anti-amyloid antibodies available. Now this is an approved clinical diagnostic modality, but at the time we were trying to show its usefulness. And what the graph shows there is in the lighter color that once people underwent this test and people were given that information, they were able to adjust their medication treatments accordingly in line with that. So it was a valuable diagnostic information for clinicians to know this result, and now it's absolutely required if people are going to get the new anti-amyloid antibodies. More recently, and to make it even easier for people to get a diagnosis, there's been a revolution in blood-based biomarkers. So now a simple blood test in people who are symptomatic can show whether they have developing neuropathology of Alzheimer's disease. This can actually be done many years before they develop dementia, so that early intervention is possible. And the studies show that afterwards, the graph on the right, that again, people are more sure. They'll have a kind of yes-no answer whether someone has Alzheimer's disease or not. They know what therapies to initiate for that person or what therapies not to initiate for that person. And sometimes just knowing an answer to a diagnosis can provide reassurance to a patient and family. In sporadic Alzheimer's disease, we were involved in the early clinical trials for anti-amyloid antibodies. The first was aducanumab. This was actually a number of antibodies in from other trials that really hadn't worked at all. And the middle diagram just shows it was really a revolution at the time. paper came out in Nature showing, and you can see the red highlight areas where there's increased amyloid in patient brains with Alzheimer's disease. And by 1 year, compared to placebo, it had almost vanished. And people are really excited about this. 2 trials took place, the EMERGE and the ENGAGE study. We were part of ENGAGE, which unfortunately did not work out. There were some problems with the trial, and this agent didn't end up being given full approval, but it really showed the way, and it showed that ongoing trials with anti-amyloid antibodies were likely to be successful. We've been involved in the lecanemab in Alzheimer's disease study that showed a 27% less decline over time in people with the disorder. So it doesn't cure it, but people are less worse as they progress in the disease. And some people maintaining themselves at much milder states of impairment than they would have otherwise been. And we were also involved in the early donanemab trials, the phase 3 trials there, that showed up to a 35% reduction in the rate of decline. And both of these are now clinical treatments that are widely available and used throughout Advocate. In dominantly inherited Alzheimer's disease, unfortunately, if you have the gene, you're going to develop this disorder, and sometimes as young as late 30s, but most of the time in the 40s or early 50s, these patients are condemned to develop this disorder. By studying patients over time, and we were not directly involved with this, but we've learned that the pathology of Alzheimer's disease starts probably 25 years before people develop symptoms. And as they show there, the beta amyloid deposition, that orange curve, begins to go up, followed by neurodegeneration protein called tau, and the CDR sum of boxes, that's CDR-SOB, is a measure, a clinical measure of patients' functioning. And as you can see, this starts many years before time 0, which is dementia. So we've been involved in the DIAN-001 trial, which looks at people up to 10 years before or 10 years after they may develop dementia, and is treating them with both an anti-amyloid antibody and a novel tau antibody agent. We know that the amyloid antibody can slow things down but not cure it, and we hope that the tau antibody, which is part of what forms the tangles of Alzheimer's disease, may be able to slow it down further. More recently, we've been involved with the DIAN-002 trial, and this is 11 to 25 years before people develop the diagnosis. So really almost at a primary prevention type of phase. And again, using now an amyloid antibody that's injectable, so people don't have to come in for every injection, and can be done at home. And starting that early may prevent the accumulation of amyloid and hopefully prevent the development of Alzheimer's disease. One of the highlights of my career has been involved in the US Pointer study, and this looked at lifestyle factors for brain health. So there were 2 groups, a self-guided group that kind of designed their own program for physical exercise, diet, and engagement, cognitive engagement, and a structured group where this was followed more closely. These 2 groups differed in their expectations, accountability, and support. And as has been recently reported, there was a difference between those. So a significant difference that the more kind of you stuck to the program, the better people did. So a little bit of change you see in that cognitive score between the 2 groups. But if looked at over time, people, the more they stuck to it, about a year or 2 younger in terms of their aging and their brain health over time. And this is the US Pointer brain health recipe there: physical exercise, cognitive exercise, health monitoring, and diet. And we are looking at ways now of how to implement this enterprise-wide at Advocate, as are a number of other sites throughout the US. And finally, the preventable study is a study that looks at whether statins may actually, in the older population, may actually, again, prevent onset or delay onset of dementia. We all know that statins reduce cholesterol, but they also have anti-inflammatory properties, properties that boost blood-brain barrier and endothelial cell function. And so in the over 75 age range, we've recruited people to this study and hope that it shows as well that, again, we can slow the progression of the disorder or stop it in its tracks. Well, we're nothing if we don't recruit patients to the study, and I'm glad to say that through our collaboration with research and AARI and now NCCT, we've done very well in our recruitment. The Alzheimer's disease and dementia studies have recruited about 3/4 of the patients, recruited to participate in clinical trials in the Midwest, and we hope to continue to beat that next year. And then finally, we participate in the Global Alzheimer Platform. This is a patient-centric nonprofit organization. It's really dedicated, really aligns well to where Advocate is going in that it's trying to improve the delivery and speeding clinical trials, which is where NCCT is going. It's also committed to promoting diversity in clinical trials. Some of the clinical industry-sponsored trials that have taken place have really not represented the U.S. population well. We did really well in U.S. Pointer, recruiting, I think, at about 30% minority populations into that study. And this is a best-in-class clinical research trial group. They have come up with something called the Citizen Scientist set of awards. So we submit patients, and they are somewhat randomly chosen, but they recognize people in different categories. And we had one of our patients recognized. He was brought to the national conference, and he's really made extraordinary efforts to participate in this dominantly inherited clinical trial. And as he says, I mean, the goal is don't give up, don't be afraid. We need your help, meaning people with Alzheimer's disease. If we don't step up to get involved in these trials, we're never going to find a cure. And the Alzheimer's Association has said the first patient to be cured of Alzheimer's disease is likely to be in a clinical trial. Thank you.
That was great. That was great. Just really amazing in a short career, Darren, of many, many years. Gone from kind of watching and waiting to diagnosing and acting. So really, really exciting work. Continuing on with our last speaker right here from Milwaukee, Wisconsin, Dr. Tom Wolf. He's our Wisconsin head of our medical and surgical stroke program, director of our endovascular lab, has been mentoring and training medical students and fellows for a long, long time. I think you were a hockey coach for a little while too. We won't be talking about stroke tonight, but still the brain, idiopathic intracranial hypertension, really an amazing study that you have put forth here and we're looking at. And so when we get to some of the question and answers, we'll see how we can expand on that too. So thanks, Tom.
Thank you. Thank you for having me. Yeah, so as you saw, we enroll in some of the stroke trials. The numbers that Dr. Gittleman presented there were inclusive of Wisconsin and Illinois, and we kind of review all that data together. We can sort of consider ourselves as a single group, but we all have our own interests, and rather than talk about the stroke and aneurysm trials that we have, wanted to come up with a different topic. And so this is something that over the course of my career I had as a fellow, some opportunity to publish on when this was starting to become something that we treated as interventionalists. Traditionally, intracranial hypertension was always a neurosurgical treatment, medical or neurosurgical with shunting. And so early in my career and fellowship, we were starting to do these stenting procedures. And that's since become the standard of care. And hopefully through this, some of my sort of academic thought and how we can approach this differently is maybe we can tailor treatment to what that individual would need. I think that's kind of the focus of all of the talks, is to try to tailor things down and give patients that individualized treatment. So things that can affect pressure inside of the head are various. You can have things from structural problems to clotting, right? You can have high pressure and low pressure, and some of these present all of a sudden. Some present chronically and can suddenly become an acute problem, can cause dementia, issues with the fluid. So there's a dynamic going on. And ultimately, an idiopathic intracranial hypertension, it used to be called pseudotumor, is back historically. How they would diagnose this was through lumbar puncture, showing that the pressure was elevated, suggesting something was occupying space, making that pressure go up. But there was no tumor or anything occupying the space, and so that's the pseudo false tumor. So these patients present with headaches typically and visual decline. Those are some, and they may hear a pulsating sound, and that's often where they will come in. These are usually young women. and they're larger body habitus. And so there's this discrete patient population that you would say that's who have this. But they don't all look the same, and they're not all women, and they may not all be young. And so there's various presentations, and we call it all the same thing. So ultimately, a quick review of this dynamic, this is how the brain is draining. So we have arteries that go in, and that's typically the focus of all the stroke research. How do we get that vessel open, or we fix something on that artery that's going to burst like an aneurysm? But this is the drainage, and if there's a dynamic problem there could be a clot that could make that pressure go up. But in a pseudotumor, they don't have that, or at least when they're showing up, that's not the primary problem, but they're suffering from that high pressure, and it may make them go blind ultimately. So the acuity of the treatment comes in, and often that may be shunting, putting a tube into the brain deep, which goes into where the spinal fluid is made to take that pressure off. And so ultimately, there's a dynamic. This is all interrelated. We're constantly making the spinal fluid. You constantly absorb that spinal fluid. It's essentially a circular thing. The arachnoid granulation is the site at which that spinal fluid is absorbed, and it's absorbed back into the vein. So ultimately, there's a circular here. When you have pathology, what came first, the chicken or the egg? That would assume that everything is equal, and in the case of the chicken or the egg, we don't actually know, and it's the age-old, where did it start? So ultimately, why does that matter? I'm not sure it's all just idiopathic, which means we don't know, it just kind of happens. And so there has to be some reasons, and at certain points, there has to be a trigger. And then that cycle, that circular, you're making the fluid, you're absorbing the fluid, at what point does it become pathological, spiral out of control, and cause people to have debilitating pain, prevents them from going to work. They may go blind and never be able to work again. There's differences between these treatments. So if even here at St. Luke's, we've had different approaches, and at times it's gone from we don't shunt patients and we'll only stent them to we don't stent them because long-term changes. There's publications to say that one may cost more than the other in the long run. So trying to find out what is actually the best for the individual is going to hopefully have one treatment and not a series of treatments. And ultimately, complications come in, and you don't want to have to do more than one procedure, and the medications aren't tolerated. There's a lot that these patients go through. So as I went from fellow into practice, that was kind of the boom, and this was early 2000s into the 2010s, where stenting became sort of a standard of care. Now there are symposiums that go for just venous disorders for neurointerventionalists. And so it's sort of an accepted, this is what you do. If you have this and you have a narrowing, there's a few criteria. Ultimately, partners down at Wake published some of the guidelines on this to look at that. And if you look at the level of evidence, while it's hard to see, there's very few strong level of evidence. And it hasn't really gotten any better since 2018 when this was published. So we do know you should look at the vein, you should measure some pressures, and this all comes down to if the patient's lumbar puncture was elevated, then maybe this makes sense according to the guidelines. We have strong evidence for that. But all the rest of it, whether we should do stenting or not, it's still kind of weak evidence, even if it's the standard of care. And ultimately, at the bottom there, if the patient needs retreatment, what should you do? Well, you should evaluate the vein and recheck the pressure, because sometimes the narrowing that you fixed might actually come back in a different location. And this isn't atherosclerosis, so you can't fix diabetes or hyperlipidemia, hypertension, and then fix that narrowing. It may be all related to the circular dynamic. And ultimately, that's what I'm trying to get at with this pilot work. So ultimately, a patient came in. I had been looking at this, doing spinal taps with an MRV before and after, and coordinating that with radiology, not seeing any difference, and saying, well, maybe you're not the right patient. So this patient came in the middle of COVID. She was due for a lumbar puncture and said, can you please do the lumbar puncture after you do that venous assessment, which is essentially going in through the vein, going all the way up, and measuring pressures across all of these areas. And this is her study. And on the top two images was before a lumbar puncture. The bottom two are after. Ultimately, this area here And over in here, you see this side has a catheter, and it may be partially occlusive. So you see it filling here when I went from the left side. So there's differences. After the lumbar puncture, that narrowing improved. And the patient had immediate improvement in all of her symptoms. All of the pressure gradients that were present and met all of the guideline criteria that were there in the beginning went away. There was no pressure gradient and all the pressure normalized just by doing a lumbar puncture. So I told the patient, you actually should be shunted. Maybe a stent will work, I don't know. She ended up getting shunted and improved, and that was the last, at least I have heard about her. I looked up in her chart. There's nothing in there, unfortunately. I don't know if she moved to a different area, but we don't have that follow-up data. That's the common theme with some of these patients I'm going to show. So I came up with this flip-flop procedure, which essentially is doing the venous manometry. That's with them in a supine position, laying on their back. Measure the standard, which is what the guidelines would suggest. Then we turn them on the side in that lateral decubitus position and do a lumbar puncture. Drain them from where their opening pressure is, which typically is high, and bring them down to low normal, and then flip them back and redo all of those pressures. So she was the first patient, and since then, I've tried to convince more and more patients to do this as a pilot, to convince even my partners of what to do. This was a male patient, actually, who was not obese at all, a very thin man. He came in, his opening pressures were high. The narrowings, he just had small sinuses. There wasn't focal narrowing, and they all got a little bigger, but ultimately the pressure gradient that was there dissipated. He also got a shunt because I didn't think a stent was needed, and he has since been better. This is another patient who actually, opening pressure according to guidelines was borderline of whether we should do the venous study, but there were narrowings. She's 100 pounds. And the threshold to do any of this venous analysis, according to the guidelines, is a 25 centimeter of water. Her opening pressure when I did this was about 27. The pressure in her head was, I can't get that there, wrong button, 34 millimeters of mercury. The correlate of centimeters of water at 27 is 20 millimeters of mercury. So ultimately, that's normal pressure. But she has this pulsatility, high pressure. After a lumbar puncture, it goes away, but she still has some narrowings. Ultimately, she developed a low pressure headache in the middle of drawing off that fluid when her pressure went down to mid-normal, about 15. She had a spinal leak and then didn't want anything else done. And ultimately, she has been doing okay with just medical therapy. This is a patient who I felt like needed a shunt, had some of that improvement. She did not want a shunt. I don't know, a shunt includes putting the tube directly through the skull and tunneling it under the skin. She said, I'm not having any of that. So I said, you're having papilledema, she's losing her vision, let's do this. Her vision improved. She still has chronic headaches. She actually had bilateral narrowings. So does she need a second stent? That's what we've been discussing, and whether or not she's going to do that, I don't know. So since 2020, when that first patient came through and I did the before and after, we've had 34 patients that have come through getting these venous studies here. That's actually not that many compared to the size of this hospital and compared to what some other centers. And that gets back to who's sending us the patients and what criteria do they have to do this. And the total number that I have done with this is 10, and they all don't want this treatment or that based on it. And ultimately, I've tried to get my partners to do this. There are reasons that they don't want. Some say, hey, that's the standard. If they have the narrowing, there's a gradient, they meet criteria. We're going to do this. That's the path of least resistance. It's actually very cumbersome to do this evaluation. They're sterile, you're moving them. These aren't always thin and easy to move patients. So sometimes, our angio table is about that wide. That's smaller than some of the patients. Some of them don't want to consider it, so we only do a component. So trying to draw conclusions from this has been challenging, and ultimately we need a bigger volume of patients and ultimately commitment from everybody. So I'm in the process of trying to get this database going, and that's kind of the stage. It's all pilot. Hopefully, my plan is to summarize this and try to publish it to just get interest from people across the country or world, ultimately. As I have colleagues that I've talked to at other centers, high volume, they're on the podium presenting about venous stenting, and they say, I would just stent it. Well, because that's the easiest thing. It's actually relatively low risk. But if it isn't the first and best treatment for the patient, should they be getting it? So how do we do it? We have to change the paradigm. Ultimately, that's my hope. But we need all parties involved. I need all the neurosurgeons to say, I will put in a shunt if it looks like the patient may benefit, or we randomize if it's not clear. There's a lot of questions that are in there, and it's beyond the scope of this here now, but there's a lot of things that we can do to even look at non-invasive ways of getting this information, because sticking a catheter all the way up to here isn't actually comfortable. As soon as we enter into those venous sinuses, they feel the pressure. They're complaining, oh, that hurts. And so you hang in there another minute, And so it's a quick thing. So if we can get any sort of adjunctive MR, like flow data through the aqueduct after, or these things, they will probably always involve some lumbar puncture. But the less invasive evaluation we can get, it's going to be better for the patients, and they'll trust us more too if we can dial it and say this one treatment is going to hopefully get you to where you need to be. So that's we'll hopefully have some more updates in a year or so, but that's where we're at now. Over here.
So now we have some time for some question and answers. I'll have Darren come back up, and Tom, you guys want to sit over here? I'll sit with you. Dean can't sit with us, obviously he's up virtually. But I want to thank Darren, Tom, and Dean, very busy clinicians, but also interested in furthering our knowledge of these processes through research. A lot of this is done in your spare time. They don't come under RVUs, and
It's
so
a hobby.
It's a hobby.
Courtney does not pay you for this, but it's okay. We need this in our system. So let me just highlight that we're lucky number 13 tonight. This is the 13th of 16 sessions to celebrate research across the enterprise this month. Amazing that our organizers have done basically one every 2 days for the month of April. So, Amit, I know you said you were traveling around this week, seeing a couple of them. So really amazing for us to be part of this also. 3 left. Which ends in the research awards, I think on the last day. I think it's the 30th. I'm not sure which day it is, but really exciting. Can't wait for next year's agenda also. So let me start out with Darren. U.S. Pointer trial, amazing study we were part of, really pivotal for the future. What can we tell our patients? What can we tell ourselves right now based on the U.S. Pointer trial?
Well, we talk about with patients this all the time, and I guess the main take-home message is there's no time like now, so it's never too late to start. But you have to put some real dedication to it. Walking up and down the stairs, doing housekeeping, not enough. One patient said, so if I walk, it can't be like I'm sightseeing, right? So you have to have some dedication to it, and we have to think of ways to support the patient, because in the study, the people who were supported more, who were in their community, they really did better. There have been other studies where there hasn't been as much support, hasn't been as much adherence of the patients, and haven't done as well. So, we're going to think of ways to try to replicate that. But we talk with our patients, certainly the ones who are worried that they might get dementia but don't have it yet. This is a lesson for them. And also the children, so people come in when they're 80, but their kids are 50, and that's when that amyloid is starting. So we talk with them as well.
Mm-hmm. Really, really important, of course. Let me ask Tom a question now. So great kind of fork in the road from your usual stroke work and knowing those vessels so well. But from the standpoint of the pseudotumor cerebri or idiopathic intracranial hypertension, again, as far as the work going forward on the procedural side, but really thinking about this from a multidisciplinary standpoint, do you think that patients would also benefit? I'm sure your answer is going to be yes, but how do you envision that in the future with medical weight loss, ophthalmology being involved, also, our GLP-1 treatments now? Is that going to help with some of our, patients with these conditions? You did show the one gentleman who's essentially a normal BMI, but also had a problem with that too. So.
Yeah, I don't think there's going to be a one-size-fits-all. I think that's probably the one of the main take-home messages. But there's no question that that's a component. And that may also help steer which direction a patient could go. If you know that their central venous pressures are 15, that's high, then maybe they're going to benefit from a diuretic. Whereas a patient where it is not elevated, they may not benefit the same. It may actually worsen their overall status and cause like a renal problem. So there's no question that coordinating the medical part of this, trying to standardize that with then a standard approach for the invasive treatments is going to be a part of this, to sort through the weeds, because there's so many that are in there, and these variability of their presentation, I don't know any other way around it. So that would be dosing. Not everybody tolerates the same dose. They don't all get the same medications, and the protocol for which you would start one and go to the next, that all needs to be standardized as part of an evaluation like this in order to know, did they get an appropriate therapeutic dose, or did they start on it and not tolerate it and then technically fail?
We'll have time for a few more questions, but I want to give a chance to anybody in the audience who has a question. I have a few more, but we have a mic, so if anybody in the audience has a question, sorry I can't take the questions virtually, but at least anybody here live, if you have one. We have a mic right over here.
Hi, thank you. Hello, can you hear me? Can you hear me? Lynn Wageneck, thank you so much for presenting today. Really excited to be here. I'm part of the team from Winston-Salem who are visiting along with Jamie and Christina. Somebody else I probably missed. This is a question for Dr. Gittleman. It's fabulous that you all were part of the Pointer trial and the preventable trial. Can you just comment about how you feel working within this larger health system where these two trials were actually run from the School of Medicine in Winston-Salem, and the relationships that you have with those teams as you're doing the work here at a distance, like many of the other clinical sites, and being a part of, a larger system where we have the sort of the rigor to have developed the clinical trials themselves, putting them into place. What does that mean for our future?
Well, I think it's fantastic. I mean, we were part of Pointer actually before we even knew about Atrium, and then we became kind of cousins there. So, I mean, there's such expertise, which has been great through Wake Forest, on these multi-site clinical trials. These are not easy to run. There's like a $50 million trial, U.S. Pointer, and trying to keep that coordinated. Their work with IT, the fabulous website that was done, the database that was done, making sure that we, stuck to the program on the intervention and the recruitment. So it was really, as I said, a highlight of my career to be part of that clinical trial. Particularly, it's nice that it's positive and that we now have a message for patients, and then we can take that from research to the clinical implementation, which I think will be amazing for our patients, and who knows, delaying people's onset of Alzheimer's disease or other dementias.
Any other questions? One from Dr. Arndt.
I should say we were late at the preventable trial. We weren't one of the early sites, but I do want to call out that our coordinator has been so good at recruiting people that he's won an award through preventable. So that Corey has been really wonderful. So.
Well, thank you, everyone, for great presentations. Really enjoyed the commentary and the data and the results. Outstanding. One of the things, as I was listening to the presentations, that really sort of strikes me is the opportunity to scale results. And you talked about translating Pointer into interventions that go across the health system. Dr. Wolf talked about taking these early pilot findings and being able to think about what's the right clinical trial design to sort of explore this question and being able to, again, leverage the scale. So I'm just really interested in your thoughts about what do you see as necessary to help drive the translation or take questions and move them from, yeah, this is just a, idea that I have or that I've been, cogitating on, and now move that into a bigger stage or across the health system. What are the things that we need to be doing in order to support that?
Do you want to take that, or do you want
At least from my perspective, it would be the sort of the regulatory components and just ensuring that there is as few barriers as possible, because as Dr. O'Leary was saying, it's sort of like a hobby. That at least this venous stuff is more of a hobby for me than the other stroke is a stroke. And while we treat these idiopathic intracranial hypertension patients, the researching of it is going to kind of outside of the scope of just general practice. So in any sort of hurdle to get the logistical components, the necessary regulatory, I think would be the biggest thing. And I know there has been work towards streamlining it, and hopefully with the NCCT that will make it easier. And I'm not sure if this certainly would help springboard from a pilot at St. Luke's to a multi-center trial, even within our extended sites within the organization. And that's actually my real hope, is that would be where a next step would be before going to outside of our organization, primarily because we do have patients, we have the infrastructure in place. It's just about connecting those dots. And I think for someone, and I've been a part of a lot of the research organization along the way, a lot of my colleagues have not been. And so I think that's a foreign concept for them, even if they're trying to enroll into some of the stroke trials and things. I think for them, it's even a higher barrier. And so that's trying to get as a general knowledge across all providers, and not just within neurosciences, but all providers, to know what those avenues are and whether there's someone there to help facilitate getting that done.
So I'll just add from my point of view, for the research part, I think part of it is just that the culture at Advocate is more focused on research now. And when we were doing the Pointer trial, we had to get the echo people to do the echoes for the neurovascular part of it, and we've had to get imaging to do our research, and it was a lot of imaging and Pointer imaging. So, and not all the services were used to that. They're used to clinically taking care of patients, and the research is important too. It's developing new treatments for the future. So it being more part of the culture is important, and I think also as we develop more support of the principal investigators, support of the the attendings to do that who may not have done research before. That's part of it. From the translation end, I'll say I've been very fortunate to be part of the care model engineering program to develop new screening for patients with dementia, and that's been amazing. And then, they're able to bring in the strategy component, the IT component, the operational component, and so on, that there'd be no hope for me to just, do this on my own. So that translation part, we probably are going to present that to care model engineering as a way to bring that across the enterprise.
Great. Well, we are at time, and before I let Amit come up here and give his closing remarks, I will plug a little commercial for Dr. Arndt. He'll be answering some of your questions, Darren and Tom and Dean, on this Friday, talking about our translational center for the Wake Forest School of Medicine, which is an incredible center that you'll be talking more about, and we'll make sure you have that virtual link to it. Again, in your spare time, midday, if you're not doing anything, you'll be able to tune in. But it will be recorded. So I want to thank everyone for being here tonight, for everything, especially our colleagues who've come all the way from North Carolina. Good weather for you here in the Midwest, so you brought it with you. So thank you for that. Amit, do you want to close us out? So.
Thank you, Sean. I want to congratulate the panel to kind of highlighting some of the important work going on here. Just in closing, I want to take this opportunity to thank each and every one of you here in the room, as well as who connected online, and for the planning committee to kind of really bringing us together and highlighting and kind of talking about important work that's happening all across our enterprise. There is going to be a reception right out here in the lobby upstairs. Upstairs, yeah. So please join us there. You can connect with all of our clinician researchers. Ask more questions, continue the dialogue. There's also very supportive research teammates who work with each and every one of them. And this model of kind of really bringing research into the clinical care setting has been something that we've worked really hard. And with our leaders expanding the research, I think that's a great model. Again, thank you. Have a great evening, and let's bring this to our patients. Thank you. Yeah.